Please, who would like to meet you, kindly introduce yourself in the chat box, your name, wherever you're joining from. We'll be glad to meet you. Thank you for joining. We're starting the webinar now. All right. Good morning, good afternoon, good evening, everyone, wherever you're joining from. And welcome to the April edition of the Get Webinar series. My name is Faith Omolade Adebayo, and I serve as a research and program officer at GET Consortium. And it's my pleasure to moderate today's session. I know that Dr. Ayodotun Babatoye, who is the Chief Operating Officer of GET, is supposed to be the one moderating, but he is unavoidably absent as he had to join another meeting, which is why I'm stepping in. Therefore, on behalf of the Global Emerging Pathogens Treatment Consortium, GET, I would like to warmly welcome you and thank you for taking your time to join us today. We would like you to share this webinar to your networks that we are live and we've started the webinar. This is an important topic and I believe it is important for everyone to be aware of what we want to discuss today. Before we go on, I would like to briefly introduce GET. GET was established in 2014 in response to the Ebola outbreak in West Africa, with a mission to develop African-led solutions to emerging biosecurity threats. GET operates across multiple regions, including Nigeria, Ghana, Sierra Leone, and the United States. And we focus on capacity building, research, innovation, policy advocacy, community engagement, and strengthening health security systems. And this edition of the GET webinar series is focused on pandemic preparedness in Africa, navigating biosecurity threats in a fragile global economy, which is why we are all here. Pandemic preparedness is often seen as purely a health issue, but in reality, it is also an economic issue and it is also a system issue. Across Africa, we understand that preparedness efforts are largely dependent on external funding. We do not have a lot of internally generated funds to ensure that we are readily prepared for pandemics, and this can be affected by a lot of factors, including global economic pressures, inflation, debt, and shifting of donor priorities. And this also means that the challenge is not about how we respond. It is also about how we ensure that these systems that we've put in place or that we propose to put in place are consistently funded. They are resilient and they are able to withstand shocks. So today we'll be exploring how Africa can strengthen pandemic preparedness by improving financing, building global systems, and reducing vulnerability to economic instability. But before we proceed, I would like to mention a few quick housekeeping notes. Like I mentioned earlier, please introduce yourself in the chat. We would love to know your name, wherever you're joining from, like your country and your expectations for today's webinar. For example, my name is Faith Omolade Adebayo. I am from Nigeria. I work at GET Consortium as a program officer. And what are my expectations for this webinar? I hope to get some insight from our distinguished panelists. Also, please feel free to drop your questions in the Q&A section at any time, and they will be addressed during the discussion segment. Drop your questions in the Q&A session at any time, and they will be discussed during the discussion segment. Today, we have a beautiful, distinguished panel of speakers in our midst, and they are bringing expertise across epidemiology, health financing, public financial management, and implementation. So moving on, we would begin with our first speaker. And our first speaker, it's my pleasure to introduce Professor Abdul Karim. She is an infectious disease epidemiologist. She's a co-founder and associate scientific director at CAPRISA. Our work focuses on HIV epidemic in South Africa, particularly among adolescent girls, and on advancing prevention and treatment strategies in resource-constrained settings. She holds academic positions at Columbia University, Milman School of Public Health, and the University of KwaZulu-Natal, Nelson Mandela School of Medicine, and she has played a leading role in building research capacity across Southern Africa. Our work has contributed significantly to global HIV prevention and public health. She'll be speaking on pandemic preparedness in the context of parallel epidemics, lessons from South Africa. We are glad to have you here, Professor Karim. If you are also excited, please use the reaction emoji to appreciate her. You can use the thumbs up, you can use the love emoji to say thank you. We are glad to have you here. You now have the floor.
Thank you very much, Faith, for that very warm and generous introduction. Greetings, everyone, and particularly to the panelists. Really excited to be part of these deliberations today. And I'm going to talk to you about pandemic preparedness in the context of parallel epidemics, partnerships, and biological countermeasures. By way of outline, I will talk about some of the challenges facing resource-constrained countries, why biological countermeasures are essential for any pandemic response, some of the lessons from COVID-19, and then how low middle-income countries, in particular Africa, has been rising to the challenge of local production, and make some concluding remarks. Faith, can you just confirm that you're seeing my slides and you can hear me clearly?
Yes, I can see your slides and I do hear you clearly.
Okay, wonderful. So I'm assuming everyone else is as well. So just a quick reminder that we are living in unprecedented times where there are opportunities for great promise and also perils, and that adversity is not new to humanity. We have faced it multiple times, and it's how we rise to adversity that counts. Now, one optimistic goal we have as the 194 UN member states committed to the Sustainable Development Goals, there are 17 of them. But at this point in time, some of the challenges in us achieving those 2030 Sustainable Development Goals include climate change, global inequality, wars and conflicts, pandemics, and infodemics. So I just wanted to show these just to contextualize pandemics within this. And each of these five challenges are actually interrelated and interconnected. For example, we have widening global inequalities. And what we're also seeing as a result of this growth in extreme poverty and wars and conflicts, we're seeing a diversion of foreign aid and budgets towards increased military spending. And so we're doing that in the context of shrinking national budgets for education, for health, for research, etc. And we've also seen, as we've been reminded by the chairperson, that pandemics and epidemics are not just health issues, they also have economic costs. And there's issues around lives and livelihoods, and that lens needs to be taken into account. We're also trying to maximize and respond to these multiple challenges in the midst of something new that we started to see its impact during COVID-19, which is the infodemic, and particularly how mis and disinformation is actually influencing our attempts to look for truth and also some of the democratic processes that are in place. Now, we are looking at some of the biggest epidemics that we see in some instances, pandemics, malaria, TB, HIV, AIDS. You'll see a disproportionate toll on low middle income countries. And here, what I wanted to show you is this high burden of disease that's already straining healthcare resources and services in the global south. And what you can see here is a combination of both infectious and non-communicable diseases. And so this national burden of disease is really important as we think about pandemic preparedness. Just in Africa alone, we've seen an average of 102 public health events between 2001 and 2022. And these the majority of these have been substantiated. And most of these have been infectious diseases, about 30% zoonosis and 5% from of humanitarian crises. And what I wanted to move towards now is thinking about how these polycrises are constraining our response capacity, but also why Africa is important. And I think what we see and what I will tell you repeatedly is pandemic risk is global, but the capacity to respond is uneven. And we look at this, COVID-19 reminded us that pathogens do not respect borders. Africa is deeply connected to global health security, and weak detection anyway threatens everyone everywhere. So outbreaks lead to epidemics, epidemic lead to pandemics. So if you're looking at a disproportionate burden in sub-Saharan Africa and we don't contain this collectively, then it becomes a threat for everyone everywhere. And what we're also seeing increasingly is that infectious diseases are no longer confined to the global south. They are also global challenges. And if ever we needed a reminder, COVID-19 did that. And now let's look at pandemic preparedness plans and what are essential components. These include the importance of surveillance and epidemic intelligence. So it's not just about collecting data, but it's also how do we translate that data into intelligence? In other words, how do we use that to actually monitor progress in outbreaks or as if they've moved on to epidemics? What's essential in pandemic preparedness plans is the medical countermeasures, specifically diagnostics, vaccines, therapeutics, and then devices depending on the epidemic we're dealing with. And these could include respirators, oximeters, and other devices. Importantly, we need R&D biotechnology capacity. We need healthcare system preparedness for the morbidity and mortality. And then we also need communications and public outreach. In essence, we need an all-of-society approach that includes regional and international cooperation. So let me focus a little bit on the biological countermeasures for now and why they're essential to pandemic responses. We need diagnostics, and let me first talk about what the measures are and then why they're important next. So these are typically laboratory-based, but the emergence of rapid tests means that the closer you get to where outbreaks are taking place, the better it is in terms of confirming diagnosis. We need up-to-date vaccines for active immunization, and that's really, in many instances, part of the end game. And then treatments to reduce morbidity and mortality. And these include biologicals like passive immunity and chemical options like small molecules or drugs, in other words. So what have we learned from COVID-19 COVID-19 is that we were able to generate an impressive number of scientific innovations in diagnostics, therapeutics, and vaccines. In fact, it was stunning to see how in less than 1 year, we had a range of vaccines come in, and we also saw treatments emerge, and we went very quickly from lab-based PCRs to rapid point-of-care tests. But what was the experiences in Africa? Well, invariably, we were at the back of the queue for all biological countermeasures. So look at diagnostics. Access to PCR kits are important, but so is PCR machines and reagents to run those tests. Lab infrastructure to deal with high throughput, which you need when you have outbreaks, epidemics, and when those epidemics are growing. But you also need trained laboratory personnel. And when you have a crisis is not when you do the training. In terms of vaccines, we see the high demand during pandemics, but constrained access. Africa, always at the end of the queue, even if we had funds available. And then the issue of when you have the vaccines and you have access is issues of affordability and infrastructure to deploy those vaccines. And then thinking about treatment where you have constrained access due to availability and cost, then the need to, then the capacity to actually innovate and manufacture healthcare delivery systems, skilled personnel to identify patients, confirm diagnosis, and initiate treatment. So when we look at access, we see that the lack of vaccine doses in poor countries were as a result of vaccine nationalism. What do I mean? And I'll just use one country, for example, Canada was able to secure more than 9 doses per person just because they were able to afford it and they could do that. And you see as you go down that while you have vaccines available, the richer countries were calling the shots in terms of access. And if you look at it throughout the world, you see, again, Africa lagging behind in terms of access to vaccines. And we're just talking about 1 dose. What are some of the consequences of COVID-19 and how, for example, they impacted HIV services without available biological countermeasures? What you saw was a reduction in HIV testing and a reduction in ART treatment initiation. Why that is important, you can glean from just this one example of an immunocompromised HIV-infected patient with a persistent 7-month COVID-19 infection. And you can see within days, the initial infection with the D614G variant, but within a matter of days, you see 11 new mutations. At day 6, what you see is E484K. By day 71, you have 417T, and by day 190, you have N501Y. So this patient, a single patient, recreated 3 key RBD mutations of the beta variant. And so you can imagine when you multiply this out, what you see is the price of inequitable access to interventions is that the pathogen thrives, and we started to see new SARS-CoV-2 variants emerging, including the last, which is Omicron. So how has Africa been responding? We see building African regional manufacturing of vaccines is necessary, but not sufficient. So if you look at the African vaccine manufacturing landscape, you see that we have about 25 active projects across Africa. What we have in Africa is significant fill and finish capacity, and that's already in place in multiple countries. But where we see a gap is in the substance capacity, where it's limited and uneven. And most of tech transfers that we see occurring from industrialized to Africa is on drug product and not the full value chain. And if we're going to make a difference, we need to be focusing on that. The real bottleneck to building sustainable vaccine manufacturing is about need, demand, and financing. And what we find is that the commercial sustainability remains fragile. And part of that is financing. And that's estimated to be about $250 million. And also, what we're looking at financing is often short term and not aligned for long term commercialization. And a big purchaser of vaccines is UNICEF, and UNICEF's market share is capped for new entrants. So it means that those who have been supplying UNICEF will continue to do that, and new people coming in is going to be an issue. So even if you have everything in place, there's no guaranteed offtake of commitments, which makes that a challenge. So we're going to be looking at ensuring sustainability of local production of treatments in the next pandemic. Some of the challenges that we need to be looking at, firstly, is we need to be investing in sustainability during and between pandemics and not kicking this off when we actually have a crisis. And these include good governance issues, manufacturing, demand and procurement, regulation, and financing. And we have the WHO mandate and pandemic agreement. We have seen from multiple analyses why the multilateral agencies, and particularly in the context of pandemics, the World Health Organization has a key, central, and critical role to play. We need transparent allocation rules. We need ethical decision making when we have scarcity, and that's always an issue when you have a crisis. In terms of manufacturing, we see the importance of regional production, that it's not just about the drugs, but it's about not just about fill and finish, but it's about actual molecules or biologics and our ability to produce that. And then how do we do the tech transfer with real absorption taking place of products being manufactured. And then we've seen and had experience during COVID of how through the Africa CDC, pooled procurement helped the individual countries, but that also needs national upfront commitments, and we need some predictable market signals so that the capacity that we're building is used properly. We also encountered regulatory challenges, and the African Union has been trying to address that, and much progress has been made. We also know about WHO pre-qualification pathways that need some review and revisions, and then we need much faster and credible review systems. During COVID-19, we saw harmonization between the more established regulatory authorities like EMEA and FDA, and how national regulatory authorities were tapping into those review processes to expedite movement of regulation on both vaccines and therapeutics. And then in terms of financing, and I'm glad there are a lot of people who will talk to financing, is that we need to be looking at longer term commercialization of the infrastructure investments being put in. We need to look at how do we build and strengthen risk sharing mechanisms, and then what is the capital investment that's needed, and the gaps that need to be filled. And here I want to dwell on effective partnerships and collaborations and how essential that is as we move forward. These are premised on mutual respect and trust. Each partner has to make a contribution. Initially, contributions may be unequal, but how do we work towards equity? And then the training and capacity building, that's an ongoing investment to fill skills gaps, both in terms of healthcare provision, but also in terms of research capacity. And Essentially, these partnerships have to enable synergy where we can accomplish more than what we could individually, and that our outputs bring added value and equitable benefit. So let me move now in the remaining minutes to look at some of our success stories. And during COVID, for example, in South Africa, a manufacturer of appliances, household appliances like fridges and washing machines and dishwashers, moved all their resources to focus on the ventilator project, and they were able to design and manufacture the first African ICU ventilator. We also had innovation in terms of securing oxygen supplies, and there were four companies that had a monopoly on providing oxygen supplies. They actually came together to carefully plan oxygen supplies as they were needed. We saw within countries uneven impacts as variants of concern emerged, and they were coming together. Their coming together helped to reconfigure and model demand as per the Ministerial Advisory Committee advisories. And during waves 1 and 2 of the COVID pandemic, we saw no hospital, whether in the public sector or private sector, run out of liquid oxygen. And we know that in other countries, for example, in India and Pakistan, how these created major challenges. Another success story through an investment from the National Institutes of Health in the US was about creating training programs. And in particular, what we saw how investments very early in responding to HIV through a partnership between Columbia University and Southern African institutions trained over 600 South African scientists in AIDS and TB research. That really put South Africa and the Southern African region in a different position in terms of responding to the pandemic. Not only were we training, but there was a multiplier effect from this training. And what we saw was how this HIV research capacity, we were able to tap into that and leverage it during COVID-19. So COVID-19 benefited from these earlier investments in terms of HIV, TB molecular platforms that were repurposed, the use of influenza surveillance systems that were in place, in terms of existing clinical trial networks that we were able to tap into for participating in both vaccine trials for COVID and also treatment. And then this HIV and TB sequencing expertise enabled us to monitor variants of concern. We also already had in place the bioinformatics capacity, and the data sharing norms that were already in place enabled us to pivot. So what are 5 key lessons from past epidemics in Africa for interventions in future pandemics that we can take into consideration? The first is our global interdependence, that we are interconnected and have a shared vulnerability. And so in putting and responding to threats, we need to think both globally and regionally, as well as at a country level, and how leadership at each level is critically important. The second is community involvement. And here, an African concept of Ubuntu, which is I am safe when you are safe, and shifting from me and the individual perspective to how you can work collectively is really important. One. Two is that when we come up with interventions, whether that's vaccines or therapeutics, if we want uptake of that, we need to co-create this knowledge and have co-ownership with community, because at the end of the day, uptake of those interventions and large-scale coverage is what offers protection. In addition, when we work together for early identification, in other words, for our surveillance, that the real identification of the first cases or threats comes from very vigilant clinicians. And as we move to One Health, and we're looking at zoonosis, we're looking at the environment, and we're looking at people and that interactions, that there are many people that contribute to identification of potential threats. And the more we can inform, the more we can educate and help in identification of early cases, the better we can respond, confirm diagnostically, and then move on to mounting other responses in terms of containment of further spread. And that what's really important is evidence-based policy and decision making. At a time where we increasingly seeing the blurring of scientific evidence with political opinion, it makes it even more important for us and all of us to really understand what evidence-based policy looks like and how that can be used for decision making. And again, this is a comprehensive approach to epidemic control and not looking for that magic bullet or silver bullet. And what we see and what we've learned from HIV in particular is the importance of global solidarity. Global solidarity shifted us from unaffordability in terms of treatment access to it being affordable. We saw that in the Global Fund for AIDS, TB, and malaria. And we also saw that with a specific country response, namely PEPFAR. And we saw some of that solidarity in the early days of COVID-19. But then when vaccines started to emerge, we saw vaccine nationalism superseding. So let me just say that I think as we think about how we prepare, how we respond, this quote from Pope Francis, from the late Pope Francis, made and captured in this New York Times editorial, I think really is the essence of how we think and how we respond. And let me quote, the COVID-19 pandemic has exposed the paradox that while we are more connected, we are also more divided. The pandemic has reminded us that no one is saved alone. What ties us to one another is what we commonly call solidarity. Solidarity is more than acts of generosity, important as they are. It is the call to embrace the reality that we are bound by bonds of reciprocity. So let me stop there and happy to take any questions or hand over to the chair. Thank you.
Wow, thank you so much, Prof, for that insightful presentation. I must say my note is now well filled up. So thank you so much. We really do appreciate you. I think one of the things that stood out clearly for me is how in many African settings, we are not just dealing with one outbreak at a time, we are dealing with multiple epidemics happening simultaneously. And that has really put pressure on the already stretched health system. And you also emphasize that partnership and collaboration is important. Preparedness is not just something countries can do in isolation. Everything really ties together. And most importantly, the success stories. Those are really wonderful things you've South Africa has done, particularly the long-term training programs that trained over 600 South African scientists in AIDS and tuberculosis research. That is quite inspiring. Thank you very much. And lastly, you mentioned 5 key lessons from the past outbreak, which I believe every participant should note that down. You mentioned global independence, community involvement, working together for early identification, evidence-based policies, and global solidarity. So once again, we are grateful. Thank you so much. I would like our participants to use the reaction emojis to say thank you for that wonderful presentation. And right now, we would be moving on to the next speaker for this webinar, and our next speaker is Tom Hart. He is a senior research fellow in development and public finance at ODI Global. Tom's work seeks to understand how public financial management can support the improved delivery of public services. His work has covered budget reform, fiscal decentralization, health financing, and public investment management. He has worked in Kenya, Malawi, Nepal, Somaliland, South Sudan, and Uganda. And before joining ODI, Tom lived and worked for 7 years in South Sudan and Uganda, initially as an ODI fellow in the Budget Directorate in the Ministry of Finance in South Sudan. He subsequently worked as a consultant for the African Development Bank, USAID, the World Bank, and ODI's Budget Strengthening Initiative. And before moving to East Africa, Tom worked at HM Treasury in the UK. He's also an honorary fellow at the University of York's Interdisciplinary Global Development Center. He'll be speaking on strengthening public financial management for pandemic preparedness in Africa. Thank you so much, Tom, for accepting our invitation to speak. We really do appreciate you. You now have the floor. Over to you, Tom.
Great. Thank you, Faith, for that introduction. I'm just going to share my screen. Great. I hope you can all see my presentation. Faith, if you could just confirm it's okay.
Yes, we can see your screen.
Great. And thank you for the kind introduction. I feel after I think Professor Abdul Karim has given us a fantastic overview, I'm going a bit more into the weeds now to talk about public financial management. So to introduce this, I'm going to talk about kind of two aspects of strengthening public financial management for pandemic preparedness. The first one is to think about how can spending on prevention and preparedness be protected. And I'm just going to briefly mention this because I think that relates to many of the issues that the last presentation was covering, but is also particularly challenging. And then for the bulk of my presentation, I'm going to look at the question of whether PFM systems are ready to spend effectively in a health emergency. So when a health emergency hits, can funds be spent effectively to respond to it? Now, I know that many of the audience that we have today are not PFM specialists. I'm going to just start with a couple of overviews of what we mean by the PFM system and why it's important in responding to pandemics and other health emergencies. And I would really emphasize that although we're talking about pandemic preparedness, these lessons are relevant for all health emergencies. So to take one example, just between 2022 and 2024, so after COVID, Tanzania had to deal with polio, measles, cholera, and Marburg virus disease outbreaks. And all of these need an emergency response and need the public financial management processes to allow funds to be dispersed for that emergency response. So in terms of moving on to why public financial management matters for health emergencies. So on the right-hand side, you can see what we think of as the budget cycle or the PFM cycle, going from budget formulation, preparing the budget being approved through Parliament, budget execution, so the set of processes by which funds are spent through accounting, internal audit, and other resource management processes, whether they're for human resources or procurement processes for health commodities and so on. And then finally, the final stage of budget evaluation, where we think of external audit and other accountability processes through Parliament and public accounts committees and so on. And the effectiveness of a health emergency response will depends heavily on the level of public funding and how this is allocated and spent. And so it's the PFM system that determines this, that determines how public money is allocated, how it flows to health providers, and how it's reported and accounted for. So this is the basics of the PFM system and why it's important. So when we think of preventive spending, so some of the issues that Professor Abdul Karim raised in terms of spending on disease surveillance, on laboratories, on other public health programs, we know that across all countries' health budgets, preventive spending and public health spending gets chronically squeezed. That it's common to find shortfalls in public health spending, and that primary health spending is squeezed by hospital budgets and by curative spending. So here in the UK, there's been a debate around introducing a new category of preventive spending, which would aim to ring fence and identify preventive spending in the same way that capital spending is commonly classified separately. So, if you like, the kind of ideas that were put forward by some health think tanks here in the UK was that the health spending budget, as well as having categories of recurrent spending and capital spending, it would also have a classification of preventive spending that could try to ring fence that spending so that it wasn't cut back. That's not been introduced, but I think that illustrates the kind of example of how difficult it can be to maintain spending allocations for this kind of spending. And of course, this challenge is magnified in where countries have kind of even more challenging fiscal conditions, and which many African countries face, where health spending is already low, where it's being squeezed further by aid cuts and also by rising interest costs. So the chart on the right shows the primary balance, so the difference between expenditure and revenues in Africa, which has been reduced down either because taxes have been raised or spending has been cut since the pandemic, but also shows the fact that rising interest costs across Africa are taking up an increasing share of spending as well. And this, of course, makes these fiscal conditions make it even more difficult to protect preventive and preparedness spending. So now moving on to public financial management in a health emergency. So in a health emergency such as COVID or responding to other health outbreaks, PFM systems are put under strain during these crises. They need to rapidly cost funding needs and make sure budgets are formulated in line with those funding needs. They need to mobilize new money and repurpose old money, so existing money in budgets. They need to ensure that money reaches the front line quickly by adjusting spending controls, whether that's reaching hospitals, other health facilities, community health workers, stepped up surveillance, and so on, and also procuring new health commodities, whether that's new vaccines or other new treatments. And at the same time, need to maintain strong reporting systems to enable accountability. And, this is a challenge across countries and across crises. This is not an African problem. This is a global challenge. So I'm going to now move on to looking at some of the lessons that we have learned from COVID-19. And this is adapted from an excellent WHO report, which looked at the lessons for public financial management from COVID-19. And I recommend that as reading for anybody who's interested in exploring this further. And going back to that budget cycle that we looked at before, this kind of set out recommendations across each of the steps in the budget cycle, from budget preparation, how budgets are prepared, how money is spent, budget execution, and how it's accounted for in terms of budget reporting. So just to go through each of those, the first step on the budget preparation is making sure that the procedures for emergency funding are very clearly in place. So that when an emergency hits, the procedures for authorizing rapid spending, and for transferring it and for accounting for it and so on, that those are all very clear in terms of how that can be activated. The second thing that's needed is providing flexibility with accountability in resource allocation and management. We know when an emergency hits that budgets may need to rapidly be reconfigured, and funds spent on the new emerging needs and the demands of the emergency. And the budget process and budgets need to make sure the flexibility is there to do that. We also need to ensure that transfer modalities are in place to provide emergency transfers to subnational entities and purchasers. Across many African countries, primary healthcare, for example, is commonly devolved to be the responsibility of local governments or regional governments. And they're the ones at the front lines of the emergency response. So money needs to be able to go to them in a reliable way for them to respond to the emergency. And also, many countries set up extra budgetary COVID funds in response to COVID. Many of these have been closed down, but where any kind of extra budgetary fund, whether it's an off-budget contingency fund or otherwise, where those exist, standard operating procedures for those and how they're going to be used in an emergency needs to be developed well ahead of the emergency. In terms of moving on to budget execution, emergency spending protocols that allow for the fast track authorization of spending need to be revised. Emergency procurement protocols need to be in place. So as Professor Abdul Karim set out, when new vaccines need to be purchased, when oxygen needs to be purchased for hospitals on a rapid basis, those procurement protocols that allow for emergency spending, but also ensure that the accountability for procurement is there to avoid corruption risks, those all need to be in place ahead of when a crisis hits. As well as procurement of health products, we also need to think about whether in an emergency, if additional staff need to be hired to respond, or there needs to be additional contracting with private providers in emergencies. You know, as in the case of COVID, where private hospital capacity might have been contracted in to respond. The regulatory frameworks and the procurement frameworks for procuring additional staff and private providers needs to be in place and updated as well. And we also need to ensure that processes are in place to provide direct funding to service providers through the budget system. Going back to the example of where local governments are responsible for primary health services, often local governments may purchase or do the financial management arrangements on behalf of primary facilities. And that those processes may work in kind of normal times, but you know, in COVID, when we had lockdown, when we had restrictions on movements, we'll often see that the funding actually is most efficiently spent by the frontline providers, and so the processes need to be in place so that that funding can get to them. And the corollary of that is that if frontline service providers are going to be handling increased funds during an emergency, that their financial management capacity for doing that needs to be built as well. So that's another important aspect. And moving on to budget reporting and ensuring accountability for the funds spent. At the time of the COVID outbreak, the managing director of the International Monetary Fund said, spend what you need to, but keep the receipts. So if you like, this is moving on to the keeping the receipts and making sure the accountability is there where emergency funding has gone through these emergency procedures. So the first thing is to ensure that the National Financial Management Information System has the ability to report emergency related health spending, and that emergency spending can be recorded and accounted for in the normal ways. And a second point is to also make sure that the public, where emergency spending happens, some of the normal controls may have been relaxed. So because those controls on that spending have been relaxed, the accountability and the transparency of that spending needs to be enhanced to make sure that we avoid misuse or corruption. And so one recommendation WHO made is the public transparency of emergency spending can be improved through providing more details through open online platforms. Having set out these kind of general lessons from COVID-19, I now want to move on to an example of how the lessons from COVID for PFM systems in emergencies are being kind of operationalized with one example. And I'm going to do this through the example of the Jordan's program with the International Monetary Fund's Resilience and Sustainability Facility. So just to introduce the Resilience and Sustainability Facility, this is a new facility the IMF established in 2022 to help countries build resilience to external shocks and ensure sustainable growth. It provides concessional financing to help countries address longer term challenges. And at the moment, those are focused on climate change and pandemic preparedness. And to date, of the 27 countries which have agreed RSF programs with the IMF, more than half of those are in Africa. I'm looking at Jordan's Resilience and Sustainability Facility program, its RSF program, because although they have focused on climate challenges and on pandemic preparedness, Jordan's is the first to include attention to pandemic preparedness. So Jordan agreed a $700 million RSF program with the IMF in June last year, and it was the first program to include reform measures on pandemic preparedness. So the conditionalities in RSF programs get called reform measures by the IMF. And pandemic preparedness related to 4 out of the 13 reform measures in Jordan's program. The other reform measures in the programs are about integrating climate risks into PFM process and also about financial and efficiency reforms in the energy and water sector. So Jordan is obviously a water scarce country, so that's extremely important for its longer term sustainability there, and as is it reducing the kind of fiscal burden from inefficiencies in the energy sector. And those are the kind of reforms that are very common in the RSF programs that we've seen in other countries as well. And these to go through the pandemic preparedness reform measures in Jordan's RSF arrangement, that these were covered 4 areas. So the first area was about clarifying the roles and responsibilities in health emergency response and asking the cabinet to make sure that that was clearly defined. And, that is like a precursor to, if you like, the PFM arrangements to make sure the broader roles and responsibilities are there. And I think that had been highlighted in a previous study that the World Bank had done for Jordan looking at its pandemic preparedness. The second area was relating to formulating an emergency ready health benefits package. So specifying the set of health services that should be available during public health emergencies in line with WHO recommendations. So we can think of if the PFM, a lot of the PFM system is the how, this is also making sure the what of the spending is going to be clarified ahead of emergencies. The third area was really looking at the sources of financing for health emergencies. So making sure that the budget manual that Jordan uses to manage its spending clarifies the financing sources for emergency response through sources such as the contingency funds and reprioritizing existing spending, and also clarifies the triggers for use of those funds when an emergency reaches the threshold that kind of funding can be used, and how that funding is going to be dispersed. And then the last reform is on improving the monitoring and reporting on health emergency spending. So in line with those kind of broader recommendations that we saw from the WHO, it commits the Ministry of Finance to issuing the kind of data reporting templates Again, changing the budget manual to reflect those, and then importantly, mandating the quarterly reporting to the cabinet and to the public on health emergency spending when that's in place. So that is, I think, an illustration of how some of the broader lessons that we've learned from the pandemic on making sure PFM systems are ready to respond to pandemics are getting incorporated into PFM reforms, as we see from Jordan's example here. So now, just to conclude with a kind of four thoughts that I take away from this, which is that maintaining spending for preparedness and preventive action is a challenge for all countries, but it's a particular challenge for those countries where health spending is already low, for those countries facing aid cuts, and who have the most binding fiscal constraints. COVID-19 exposed weaknesses in many countries' PFM systems for responding to health emergencies. And we can learn the lessons from COVID to reform PFM systems now so that they're ready for the next emergency. And as we've highlighted with the Jordan's IMF RSF program, that there are new sources of international support available to do this. And of course, as well as the RSF, there's also the new pandemic fund managed by World Bank Secretariat that was set up as well, that provides much broader support to pandemic preparedness as well. Thank you very much.
Thank you very much, Tom, for that insightful presentation. That was great. Thank you very much. One of the things you highlighted was what PFN is. You mentioned that PFN system determines how public money is allocated, how it flows to health providers, and is reported and accounted for. You also mentioned the WHO PFN procedures, which includes budget preparation, budget execution, and budget reporting. You gave the IMF Resilience and Sustainability Facility. You also mentioned the Jordan's program, which involves the roles and responsibilities for health emergency response and monitoring, reporting on health emergency spending. Thank you very much for that beautiful presentation. I hope that our participant has also learned one or two things from this presentation. Kindly let us appreciate our speaker with the use of emoji. You can use the thumbs up, you can use the love emoji. Let's say thank you for that beautiful presentation. Thank you very much. We appreciate you. Right now, yeah, we'll be moving on to the third speaker for the day. And if you are just joining us, thank you very much for joining the April edition of the Get Webinar series. Like we usually say, without you, there is no Get Webinar series. So thank you for joining us and for spending the past 1 hour with us. We'll be moving on to the third speaker. We have 4 panelists for this webinar this month, and right now we'll be moving on to the third speaker, who is Maurice. I apologize if I pronounced that wrongly, and I'll be reading his biography briefly. He's a senior economist at the World Bank and working at the nexus of public finance and health. He is interested in how public financial management reforms can be an enabling force for efficient and equitable service delivery. His work is currently focused on reforms in the Africa region, where he leads various analytical programs that include how to deploy disruptive technology solutions. During his time at the World Bank Independent Evaluation Group, Moritz led various evaluations of World Bank support to public financial management reforms and has written extensively on what makes financial management information system effective. Prior to joining the World Bank, Maurice worked as an advisor to the government of Zanzibar, Tanzania, where he supported authorities in budget management and the introduction of health finance reforms. Maurice holds an MSc in Economics for Development from Oxford University and an MA in Economics from the University of Aberdeen. He'll be speaking on safeguarding health financing for pandemic preparedness in a fragile economic environment. Thank you very much, Maurice, for accepting to speak. You will now have the floor.
Thanks so much, Faith, and thanks so much, everybody, for joining us here today. As I listened into some of our distinguished speakers before, especially Tom, I realized that there is quite a bit of overlap between Tom's presentation and my presentation. So I'll try to keep it short, which will also be in the interest of freeing up some space for our panelists and discussion afterwards, if that's okay. So with that, let me pull up my slides. There we go. Can you see them?
Yes, we can, but it's not on presentation.
Okay. Yes.
Perfect.
Just give the system a minute. So similarly to what Tom had raised, that is on safeguarding health financing, is the question, okay, well, what does it mean to protect spending for investments in preparedness? And so that is the first question. And why is it that it can be so challenging to do that? And what are some possible reform actions? So we'll spend quite a bit of time on that, and then secondly, what I wanted to bring up is this question on well, once an emergency event does occur, where do resources come from to allow us to react? That's so what? So on the first question, right? How do we prioritize investments? And that is something that one would have to think about during quiet times. And here, right, as Tom had already mentioned, that there are political commitments that are difficult to follow up on. They can be short-lived. And part of the reason for why these political commitments are short-lived is that the results aren't immediately obvious, right? So being better prepared is not a result that the population immediately sees, right? And competing priorities tend to crowd this out. It's very much similar to what you see in defense spending, where, right, if there is no conflict, defense spending just seems like, right, deterrence is not something that is a very visible result, that and in the same way, preparedness spending is not a very visible result. The other challenge that we see with this is that the area is inherently multi-sectoral, right? And it's not always entirely clear what preparedness spending actually means, and you'll see different variations across countries. So how does one protect health financing around that? That if clarity on what it actually means is unclear, and if there are stakeholders involved that go well beyond the health sector, including, of course, local government, but also many other areas like veterinary services and so forth. So that's clearly a challenge. And then lastly, right, if you have a coordination challenge, right, and if there is lacking clarity on what it means, and you have so many stakeholders, that also will affect accountability. Right? So if you say there is, healthcare spending is clear, and one can prioritize that in the budget. Once you think beyond health, where there isn't a clear counterpart, where there isn't a clear contingency, it's much more difficult to go about doing this. So how does one potentially address all of these challenges? And Tom had reflected on some of the ongoing developments in the UK, which are very interesting. right around coming up with a kind of a separate category to capital spending where one can ring fence. Another area that's been brought up, right, as a way of getting at that is similar to is where one tags the budget, right? So one commits to certain expenditure items, right, or certain budgetary items across entities in government, and says, okay, right, at some point, a decision needs to be made on what preparedness spending and what would actually mean, even if there are differences across countries, from a budgetary perspective, right? What are interventions that are high impact interventions that must be there, and where there's political commitment behind those, right? And what's the budget against those? And once one has some sort of commitment against those, you can say, okay, these items in the budget will be clearly reflected, and then one can set up a mechanism within the budget to see the extent to which these items have actually been approved, whether funds have been released against those, whether these activities or interventions have also been executed and are implemented on, and so forth. Right? So then, but that requires a very specific PFM process. Right? It can be done through tagging, can also be done through other mechanisms, where one can ensure that the various items that have been committed on as high priority items across government can be tracked. That it can be a dashboard can be set up, or other mechanisms. That, or one can, if a dashboard is not possible, one can simply run a crosswalk table over a budget document and share those. That's to see what's actually in and what's out, and what does preparedness spending actually look like in a country at any given time, right? And then that is something, once that is in the budget, once this mechanism exists, that's something that can be monitored and tracked and followed up on, right? And that allows stakeholders then, including the legislative, to ask questions on why certain items that may have been agreed on that are considered high impact interventions have not been approved, or if they have been approved, why they have not been funded, and so forth. Right? So it's inherently difficult to do, right, to follow up on political commitments, but there are technical ways of developing the budget such that priorities or stated priorities can be followed up on whether they're actually followed through on. Right? So this is a very important differentiation, and that's some of that happens already. Right? I mean, other areas, including nutrition, for example, are going in that direction. Right? The world that we live in is inherently complex, and it's not always possible to allocate spending or to follow up on spending in one sector at a time. But there are ways to addressing this, right? And I think that's the main message that we want to get across here. We can discuss more of that later if there is demand. So what we want to get at with the next slide is having a priority and what that looks like would be extremely important, right? And so that it's not so that there is a strategy in place, that there is a commitment in place, and there is a way to follow up on these things, and that that there is a regional a regional debate can be had on what's in and what's not, and all of this provides legitimacy through some legislative debate, right? And then one can rally behind a regional agenda, right? Who has or to see whether countries have such a process in place, and then and if such a process is in place, then it gives an entirely different meaning as to how much is being spent on preparedness spending. And one can identify a gap, and one can have a conversation around how to fund that gap. But unless one has this clear definition and the process in place, the conversation around whether spending on preparedness is sufficient or not sufficient is always going to be a conversation that's very elusive, right? And that's never specific and concrete around things that need to be done, because any estimations on what's actually being spent and budgeted and prioritized is always going to be within the eye of the beholder, right? And that's very difficult, right? Because then it's difficult to hold anyone to account. So it's would be a call in that sense for taking regional action, right? What is it the countries are doing, and how can countries not rally around specific spending target, but a process, right? Such that this legislative debate can happen, right? And such that the how much question can be pinned down, and the gap can be identified, and the meaningful conversation can be had around how to fund that gap and follow up on any gaps in a meaningful way. The second item that I wanted to bring up today is the mobilizing questions. And Tom has discussed some of these things in various in some of his slides. But the question on where resources are going to come from once there is an emergency event is a very important one, and it's not a decision that should be taken lightly, or that countries should be unprepared for, because it can be very expensive, right? It can be expensive in terms of lives lost, of course, right? But it can also be expensive in terms of accessing these resources if there is no plan in place on how to go about doing that, because of the opportunity cost of capital, because of interest rates, and so forth. So having a specific strategy in place on how to access is something that one should be cognizant of and should be exploring during quiet time, such that there is an action plan in place for when for when there is this emergency event. And here, as I would propose a slightly different framing of the question of mobilizing money, because there's the question of how does one access resources immediately? What's the first point of defense? And so without accessing additional money, what is it that one can do through the given PFM systems? And then there are the questions of how does one mobilize additional resources that may not have been in the budget, may not have been approved, and how does one expedite these processes? And making that distinction is particularly important, right? Because, as I mentioned earlier, to minimize the cost of capital and the opportunity cost, right? So just to give an example, if one were to set money aside every year, right, for in a fund, but there is what that means is that there is and the country is borrowing money. And it means that the money that government has and is setting aside could have been used elsewhere, right? But because it's not being used elsewhere and government borrows instead, government has to pay interest on the money that it borrows for, right? So it's very important to take into consideration efficiency concerns in all of this. And what I want to go through here now, right, with the various options to mobilize, are some of the things that Thomas touched on. Some of them he hasn't touched on, but we can go in some more detail on this. And so the first item, right, what is that you'll see here? What's the first line of defense, right, through use of existing budgetary resources, right, and we'll differentiate that from mobilizing resources through additional. Through accessing additional resources to where a supplementary budget would have to be passed. And here on the first two rows, you'll see reallocation of the budget. Right? What is the mechanism in place to move money from one line to another, from one entity, from one program to another, from one department to another, from one purpose to another, to does not necessitate accessing additional resources, but it requires PFM systems that allow one to do that. Because it doesn't require accessing additional resources, it is a mechanism that can act as the first line of defense. Right? So you have an emergency event on day one. On day two, you want to be able to hit the ground running. Right? And for that, one needs to have PFM systems that facilitate moving resources around to provide liquidity to the entities that are going to lead this response. Right? So, right, some of the trade-offs you'll see here on the last column is that clearly one can do that, but it will also mean that other expenditure items would have to be foregone. Right. So we have seen this during COVID, right? That like moving money around means that moving money that means that it will be missing in other parts of government, can be within health, but can also be drawn down from other areas such as social protection. And the other is that there are, of course, limits to how much one can reallocate, right? So this first line of defense will only get one so far. The other item that we can on mobilizing resources is that a contingency budget line is something that many countries have in place, which is something that would have to be approved during the budget formulation and approval process, and can then be accessed, right? So it means that one does not go through a potentially lengthy supplementary budget process to access these, and then resources will be available as a first line of defense through the existing budget. But again, that tends to be a relative small share of the budget, and it comes with some accountability concerns potentially, right? If the rules around that are too loosely determined. So those are the two main mechanisms on the first line of defense. And one can think through a whole host of other issues for a response, right? And for mobilizing additional resources. The most intuitive and obvious would be the issuance of new debt. That's something that higher income countries would tend to do, because if they have access to capital markets, the main benefit of that is that the opportunity cost to park capital aside is very low, right? So if countries have confidence that they can do that, they don't need to worry about things like a reserve fund. They can just go to they can just issue new debt and go through a supplemental budget to make sure that they have the legitimacy to spend. Borrowing can be costly, especially for countries with low credit ratings. Another option would be to go through a contingency credit line, which is something that the World Bank or other MDBs offers, right? So that essentially triggers the credit line would be triggered through an emergency event. Can be a pandemic, can be a climate-related event, and the benefit of that is, again, there is no need to park capital, right? The opportunity cost is not there, or is limited, and borrowing would be generally on more favorable terms, right, than just issuing new debt if the credit ratings are low. The opportunity costs that are there is that there are, of course, with the World Bank, as with other institutions, very specific IDA allocations for countries, and some of those could potentially be tied down when they're not used. Another option would be a reserve fund, right? Reserve funds means that available resources effectively need to be put aside. And here the main issue is that if resources are being put aside, as I mentioned earlier, it does come at at a significant opportunity cost for investing, spending today, and or borrowing today, right? So if the interest that the reserve fund can generate is less than the interest paid for borrowing money for recurrent spending, there is effectively an annual loss, right? And that is worth taking into consideration. Right? There is an efficiency loss in all of this. And then there are regional insurance mechanisms, right? That would be the last item I would want to bring up. And that would require pooling amongst regional peers. And it's something that we have not seen a whole lot of, and requires all sorts of coordination mechanisms that can be difficult to achieve. Again, some of the benefits is there can be quick access to resources. And if one works with the private sector, much more effective costing would be done than if the public sector on its own would go about doing that. However, right, as we see is that these markets tend to be not very well developed, and these insurance mechanisms are not widely available. People tend to talk about reliance on external donor support, right? So that comes with its own set of challenges, as we all know, and development architecture is shifting as we speak. So, of course, being able to access external resources is always a preferred option, but one may not always be able to rely on that. And that's something that one needs to be cognizant of as one develops the resource mobilization strategy. With that, let me stop here to free up some space for others, and of course welcome any questions. Thank you. Back over to you, Chair.
Thank you very much for that beautiful presentation. It was very clear and practical. And what really stood out for me was the three-stage approach. You mentioned that we prioritize, we mobilize, and we act, which gives a very structured way of thinking about preparedness regarding financings and all. Thank you so much. Right now, we're moving on to the next speaker as quickly as possible so we can have a discussion segment at the end of the presentations. Thank you so much. Please let's use the emoji, thumbs up, love emoji to appreciate our speaker. Thank you for that beautiful presentation. We've learned a lot. Thank you very much. All right. Yeah, so we'll be moving on to the final speaker for today. Like we usually say, the last speaker, but not the least. We have in our midst Mr. Boniface Albano. He is a public and global health specialist and also the regional program manager for global health security at AMREF Health Africa. With over 35 years of experience, he leads efforts to strengthen resilient health systems across Africa. He works closely with government, partners, and regional institutions. He currently oversees large-scale immunization and health security programs across multiple African countries, with a focus on addressing emerging public health threats and advancing universal health coverage. It's a pleasure to have such an important person in our midst with over 35 years of experience. Mr. Boniface, thank you so much for accepting to speak. You will be speaking on translating financing and policy into action, strengthening pandemic preparedness systems in Africa. Thank you very much. You now have the floor.
Thank you, Faith, and good afternoon, good morning, everyone, wherever you are. I know we are racing against time, but I'll try to speak because I have the privilege of speaking last, having listened to my fellow panelists, and I think we have had really the core science and basics and critical elements on financing and public health financing. So Mine is really to speak on translating all this theory into action. And I really speak largely as a practitioner on the ground, really speaking in an advocacy voice, but also really facing the issues head on. For the sake of time, I'll just spare everyone from introducing this organization that I work for, an international organization based and headquartered in Africa, in Kenya, but with a presence in many countries in the globe and offices in North America and Europe. I will also not dwell much on this slide. I just wanted to center my presentation in terms of why I'm speaking, maybe the way I will do. In global health security in AMREF, we focus on 4 pillars: community health system strengthening, disease surveillance and intelligence, strengthening public health institutions and civil society organizations, and strengthening laboratory and diagnostics. So let me quickly zoom into what I have identified as maybe current key issues when it comes to really translating financing and policy into action in Africa. Firstly, I think the biggest challenge we are facing is the siloed nature of approach to addressing issues of pandemic preparedness and response, particularly when you look at the national action plans for health security, what is called as the NAPS. I think this is an initiative led by the World Health Organization post the revised adoption of the revised international health regulations. So the issue we see here is really the verticalization and standalone plans by different sectors. Our own security forces, the military, who play a large role in terms of outbreaks and disasters, have their own plans. If you go to the ministries of health, in most cases, you will even find plans for the expanded program on immunization sitting alone. You will find the programs on deployment of medical countermeasures from the primary healthcare maybe. And you find even the environmental and disaster management aspects also standing alone. You go to wildlife and management, yet the interface of most, particularly when it comes to disease outbreaks, is non-negotiable. Secondly, we also see largely the way we resource our pandemic outbreaks and emergencies, it's reactive rather than maybe proactive. We wait until a disaster happens, until an outbreak is with us, and then you see everyone calling people around, can you come and contribute whatever you can? We need to mobilize resources to address or to mitigate and maybe contain these disasters, which in most cases is quite expensive, as we all know. The cost of repair of our health is way, way much higher than the cost of making our own health, promoting our own health and preventing even outbreaks from scaling up into pandemics. My colleagues have already spoken largely on item 3, which is really the unsustainable and maybe at times unfavorable external funding, which usually comes with conditions. We are all aware the current headwinds and tug of war between, maybe at this point in time, you look at the US government initiatives where they're dangling the carrot, we'll give you so much money, you give us access to your pathogens, and now it comes issues of sovereignty and throw in there. It's really not at times workable. So again, when we look at the from a very practical perspective, most nations, most member states, and particularly in Africa, we almost have zero ongoing surveillance at community level. Yet that's a point which we are missing, because once outbreaks are detected at community level, we are able to trigger early actions, response, investigations, confirmations, and then deploying proper containment measures. We also see, tied to the issue of maybe international aid development, the tussle or the hustle between geopolitical regions. We saw this during the negotiations for the revision of the pandemic health, for the international health regulations that were adopted last year in 2025. This balance of national sovereignty, which is quite a strong and buzzword, versus international funding support. We see this tension on one end where on one end we have regions who have access and control of technology is particularly for, I think Professor Karim spoke earlier on about the issue of manufacturing. So we have on one end people with technology, they have the means to do, and then on one end, we have systems that are weak, lowly funded. They have limited capacities to respond to issues. The disease burden is growing every day and exposure is high. So how do we balance this really for ensuring that everyone is safe? So just to quickly zero in, as I said, I will kind of rush through my submissions. I am really anchoring my submissions on the recently adopted revised World Health Organization Pandemic Agreement. And in my view, there is no policy document that is as critical at this point in time than this one. All what is required is to fully implement it and enforce it, monitor it, track all the commitments there, which I believe could be a game changer in terms of really navigating issues of biosecurity in our fragile economies and even globally. So I will cite 4 articles really, and I hope the audience can take time and look at them in detail because I will just really scan through. Article 4 is about pandemic prevention and surveillance, and it calls for early detection and control measures at community level. This is key given the fact that if anything unusual is happening, it usually happens right at the doorsteps of our communities. We need to strengthen mechanisms to enhance capacity at community level. Again, this is why it's critical to have this ongoing community-based surveillance, very, very strong at every level. So this will facilitate really actions for early containment, as I said, and stop the spread. I think one of the colleagues here really pointed at the issue of the One Health approach. This is critical, looking at the growing nature of zoonosis. If all countries can develop and implement and review their national policies to ensure that the One Health approach is embedded as it relates to pandemic prevention, preparedness, and response, including, and I keep on stressing on this one, engaging our communities. That's Article 5. So if you look at Article 7, it speaks to the healthcare workforce, health and care workforce. And again, I'm laboring on the integral part and the really foundation of community health workers. If we can strengthen national capacities and designate or establish at all levels, at national, sub-national, and even regional, multidisciplinary teams, this will go a long way in ensuring that we are able to identify, we are even able to prevent, which is quite critical, but more importantly, respond timely. So investing in community health workers' capacity is key for us. As I said earlier on, anything unusual or new happening in communities, it can only be picked by communities themselves. And if we have well-equipped, motivated, and trained community health workers, they will be able to raise the alert early, triggering early, again, response from the health system, leading to investigations, testing, and confirmation. And finally, the aspect of sustainable financing. I will not labor, this has been really unpacked by the last 2 speakers. But we really need predictable financing. If you look earlier on, I had one of our panelists really speaking about some of the commitments that most governments have made. Closer to home in Africa, we remember as long back as 2001, the Abuja Declaration. If you go back and look how many countries are fulfilling that 15% threshold of health budget financing, you go back now to the recent Lusaka agenda, which again is speaking about looking at really the localization agenda for resource mobilization. So if we cannot, as African nations, fulfill or commit ourselves to enact those commitments, we still have a long way to go. Domestic funding is critical, and it should be predictable. It should be planned for, and otherwise, it will be very, very difficult for us to deal with these pandemics and disasters. So just to wind it down really practically, I also argue and present, really summarize these whole elements when it comes to financing. That is critical to balance between national domestic investments and external funding. And I still call for a stronger commitment really to strengthen financing for surveillance at local level. Because if we don't address those gaps and leverage the potential of our community health workers, we still stand to not be able to address issues of biosecurity that faces us every day. I have already spoken about the interface of human, animal, and environmental health, and surveillance should cut across really, where we don't want just the people from agriculture, from wildlife, from the environment, from the human health aspect are really running parallels or separately. There must be efforts to bring people together in a multi-sectorial plan. Earlier on, when I spoke about the fragmentation of the national health plans for security, if they are not brought together, we will find ourselves really struggling to improve our health security amidst the threats. Progressive policy formulation is critical to address biosecurity. And the central part here is really the issue of data. It's not just about data collection and use, but it's about critically the issue of sharing, the issue of being transparent at national level, at regional level, and more importantly, international. Cross-border surveillance is very central here, where there must be a will and maybe some really frameworks and mechanisms to ensure that anything to do with pandemics data is shared. And this must really be rewarded and strengthened, not criminalized. We remember in the COVID era when Botswana, the identification of the Micron COVID virus, and how then it led to closure of borders, isolation. So if these things are not addressed, we will still remain at high risk of being really at the mercy of these outbreaks. And finally, global solidarity, as I said, it's critical. I think the biggest lesson again from COVID, what we saw is that our diseases do not know and they don't respect borders. So, and no one, if someone in Ethiopia, someone in Nigeria, someone in Lesotho is not safe, someone in Brussels or in New York or in Vancouver will not be safe. We saw it recently with the Mpox, where cases were found in Belgium, yet some people thought this was a Central Africa and West Africa issue. So global solidarity is critical. If your neighbor is not safe, and you cannot be safe from these threats, and we should appreciate that the fragile health systems in Africa will not just be a problem for Africa, but it will be a problem for everyone. So investing in strengthening weak Africa health systems, it's not just an act of solidarity, but it is an issue of own self-interest. And so because national and international health security is for everyone. So I will stop here, Faith, and hand over back to you. Thank you so much.
Thank you so much for that brief presentation. That was quite insightful, although it was short, but it was well packed. Yeah, thank you very much. You clearly mentioned the gap between policy and actual action, instead of always how do we put all these policies into action, especially with issues like the fragmented national plans, reactive funding, and over-reliance on external support. You also mentioned One Health, focused on One Health, how we have to ensure that this systems are put in place to help us. And finally, you mentioned that pandemics don't respect borders and that strengthening Africa's health system is a global responsibility, which really ties back to the broader theme of global health security. Thank you once again for bringing that practical perspective to the discussion. Thank you very much. Please let's use the emoji to appreciate our speaker. Thank you very much for that insightful presentation. Let's show some love to them. Use the thumbs up, use the love emoji. Thank you. All right, so now we are moving on to the next phase of this webinar, which is the discussion phase. I believe we have some questions. I don't mind if our speakers can switch on their camera so we can spotlight them all, if that's okay. Thank you. All right. Okay, we would appreciate our speakers. Okay, now we'll be moving on to, like I mentioned, the discussion, and we have quite a number of questions here. We have one in the chat and we have one also in the Q&A session. But before we move into the questions asked by the participants, I would like to throw a question to the house. We have heard your presentations. They are really interesting ones and we've gained a lot of things. We've heard about how strong frameworks, financing strategies, and policies, how we can use them to better prepare for pandemic. But in reality, many countries, especially in regions like the low and middle income countries, they still struggle to implement all these strategies. There's a real struggle. So what do you think is the biggest barrier that is preventing countries from moving from plans to actual preparedness on the ground? What is the biggest barrier that is preventing countries like, for instance, Nigeria, from moving from plans, from moving from paperwork to actual implementation, implementing this for preparedness against pandemic? Yeah, thank you. The floor is now open. I don't know, anyone can go first.
I think there are two things. The one is political will and commitment, and the other is multitude of competing priorities. And so this is my plug for peace, which is we have all these wars and conflicts on the continent, which creates a lot of displaced populations. And we know that the displaced populations and the particular targeting of healthcare facilities, healthcare workers, our educational institutions, the weaponization of food security, etc., in combination is creating conditions for people for instability. And so we have the one which is shift of resources to military spending, and then we constantly rebuilding when we can, as opposed to having institutions that are strong, systems that are strong, that we can continue to grow and build. So that was really to catalyze discussion.
All right, thank you very much. Thank you for that. Yeah, I don't know if anyone wants to go next.
Maybe I can just come in on one thing which I didn't touch on in the presentation, but relates to what Professor Abdul Karim had highlighted on pooled procurement and using pooled procurement as a way for helping support African manufacturing as well. And a key for any manufacturing, the kind of feasibility of it, a key factor is going to be reliable demand. And now reliable demand means that the financing needs to be there from countries and that needs to be pulled together reliably. So I think in terms of there's really challenging kind of coordination challenges that need to be done at a continental level to make sure that the kind of the financing is there to support the pool procurement and the pool procurement needs to be there to support the manufacturing as well. So I think I just to highlight that these are challenging, and at a time when we are seeing, as several of the speakers have highlighted, a decline in multilateralism, a decline in global cooperation. I think it's just to highlight the push that is going to be needed to make these ambitions succeed, and that the kind of close working of nations is going to be incredibly important.
All right, thank you for that. I don't know if anyone else wants to go ahead. Our participants can also share their thoughts in the chat box. We would be reading that out. Okay.
If I could direct a question to Tom. There's the issue of manufacturing and financing, and then there's the issue of uneven capacity, and there's the markets and the demands. And I wondered to what extent you could share with us some of your thoughts on not end to end in one country, but looking at regional cooperation. So, just taking Africa, whether we go, what's the strengths in West Africa that we can build on that would complement, for example, one part of that process in another part of the continent, for example. Thank you.
Sure. So I think maybe to start kind of with the example of what happened with COVAX during COVID. So during COVID, many African countries receive a large amount of vaccines through Gavi, which was kind of instrumental in setting up COVID. And a lot of the COVID vaccines that were being procured by COVAX were coming from manufacturers in India. When the second COVID wave hit India incredibly hard, it put an export ban on the COVID vaccines, which then delayed those vaccines reaching countries outside, including African countries that needed them. So these kind of supply chain issues were creating demand for greater manufacturing in Africa, so that supply chains are resilient and robust. But now, we see countries are interested in promoting the pharmaceutical industry in their own countries as a kind of industrial policy, as a growth policy. But those but not every given the size of the market, not every country can have their own pharmaceutical industry. So there does need to be kind of, if you like, regional cooperation about where the kind of manufacturers can emerge, building on existing hubs as well. But that's going to take some countries effectively agreeing that they're going to provide support to pool procurement mechanisms that won't necessarily procure in their own countries. So I think that was why I think this needs kind of regional cooperation. And in terms of the reliability, again, there was a fill and finish plant in South Africa that was set up during COVID that eventually, stopped procedures because it didn't have the demands that was being expected. So I think if we're going to see these, absolutely correct desires to promote kind of an African manufacturing pharmaceutical industry, then there does need to be very careful consideration around the cooperation around it and how that interacts with the kind of pool procurement mechanisms as well. So I think what's really important is that the kind of the financing and the procurement mechanisms need to be seen together with the kind of manufacturing ambitions as well. And that's going to take difficult decisions as well that can't just be kind of every country for itself. Otherwise, these ambitions will fail.
Yeah, thank you very much. That was brilliant. I don't know if Professor Karim wants to say something, but we have a question here. Should I go ahead? All right. So this question is in the question and Q&A section. It says, I have a concern regarding the preparation for and management of epidemics in Africa. This concern relates to the handling of samples before, during, and after epidemics to enable an understanding of the virus genomes. It also concerns the management of vaccines during and after epidemics to ensure better preservation. The long-term sustainability of facilities for managing biological samples and vaccines and capacity building for management staff. Which solution for Africa? I don't mind if I can take that again. I'll also be pasting it in the chat box. I have a concern regarding the preparation for and management of epidemics in Africa. This concern relates to the handling of samples before, during, and after epidemics to enable an understanding of the virus genomes. It also concerns the management of vaccines during and after epidemics to ensure better preservation. The long-term sustainability of facilities for managing biological samples and vaccines, and capacity building for management staff. Which solution for Africa? I don't know if anyone wants to try that. Yeah, the floor is open.
Briefings started to allude to this particular challenge in the new bilateral agreements that are being negotiated between the US and African countries. And I think it's a very serious concern. So there was a time, even before COVID-19, where there were very good multilateral debates and discussions taking place around access to material, sharing of material. This is biological material, but also in terms of data. And these were all very collaborative and cooperative with a good win-win formula for the most part. And I think, like most multilateral agreements, you always find one or two countries are not buying into what everybody else is. But I think the big issue and concern, I think, that's growing in Africa is with the initial PEPFAR sudden work stoppages. There was a whole host of conditions that were literally destructive of 22 years of investments. And then with the new agreements that are being signed, at least where we have access to some of them, it is deeply concerning what heads of governments are agreeing to without consultation with civil society or other stakeholders, and literally committing countries and to over 20 years of data provision, access to biological specimens, and we're doing that with a very short-term investment. And those are things we should be discussing widely and openly. They not only are compromising the current generation, but also future generations. And those are open sources of bioterrorism, which is one of the themes we haven't quite touched on in today's webinar. So I don't have a solution, but I do think greater transparency on bilateral or other agreements is really important. And I think that Maurice tapped and touched on some of the conditions. You know, he had a three-stage approach of redeployment of existing funds to looking at additional funding internally and then going outside. And I think he did have a cautionary note there in terms of once you go outside national funding, what the impact and implications. I would add that if we go outside the AU, what are the considerations? So let me just leave it at that.
Yeah,
Thank you.
if okay, through you, Chair.
Go ahead, please.
Okay, sorry. But I just typed my kind of high level feedback to that comment or question, really. I think the aspect of pathogen access and benefit sharing is still one of the sticky points, despite the fact that the revised regulations were adopted. But I believe up to this point, there are still teams who are still trying to fine-tune that aspect. And hopefully, the forthcoming summit, the World Health Assembly coming now, probably we are looking forward to see what will come out from there. But really what we have seen and what is required is very strategic negotiation by especially those countries who normally share out the kind of pathogens, the kind of samples that are then used to for development of some of these vaccines and medical products. So, and we have seen players like Africa CDC, I think, coming in strongly to kind of rally people to speak from one voice. I have seen a similar move from Asia, where the Asian countries are also coming as a bloc really to put that across. It's really a question of strategic negotiation that is critical to say if we give, what else can we get? Because otherwise we'll continue seeing the fact. You remember that during outbreaks, most cases, once the manufacturing countries, they stockpile, and they'll cover their populations. And at some point, when the vaccines are nearing expiration, they will be sent to us with a very short lifespan. And then when we destroy them, then we come out of the media, and then there's a vaccine destroying ceremony somewhere in Malawi or elsewhere, which I think, in my view, is really not fair. So it really requires strong negotiation and kind of block approach in a way. Thank you.
Right, thank you very much for that. Thank you so much. Yeah, we do have two more questions here. We do have two more questions here. The first one is, how can African countries balance external funding with domestic resource mobilization to ensure long-term pandemic preparedness? I believe that has been answered. However, we can take it again. How can African countries balance external funding with domestic resource mobilization to ensure long-term pandemic preparedness? And the last question, sorry, I wanted to take the two together because of our time. The last one says, how do you suggest the pandemic preparedness related research be supported for early detection and innovative vaccine creation and production? If a percentage be given for preparedness, prevention, and management, how much would you give for each financing? I'll be posting the questions in the chat box again. Yes, thank you.
I could come in here if Faith, if that's all right with you.
Yes, please.
Yeah. So on this question of transitioning to domestic resource mobilization and transitioning away from ODA, I think it's a very important question, and it's a question really that every country needs to answer for itself, and it's a question of general revenue management and expenditure policies, and the kind of the recognition that some things will have to be taken on by domestic resources, and that puts public financial management in at the center stage of things, right? Because things that may have been procured before, things that may have been managed before by outside agencies will have to be taken on, and it's not a one-to-one relationship, right? So it's important to work through how much it might cost government and what the trade-offs are going to be to take some of these things on, right? So right, if we are working in the health sector, there's very little that we can effectively do about resource mobilization, right? But we can advocate for a more appropriate share for health and evidence that funds have been spent well, and within that, then there's the question around preparedness spending and all of these items that we discussed earlier, right? So how does one shift towards an explicit conversation around this, right? What is preparedness spending actually? What does it mean, right? For any country at a time, right? Countries take different perspectives. And then once we can our stakeholders in countries can come to an agreement of what it means, then one can have a conversation around how well all of these things should be resourced. And that's then a conversation that needs to be had and trade-offs that can be made. But unless you have this explicit conversation, it's very difficult to do that. And that goes also to the second part of the question on what share should be spent on preparedness. And it's a very difficult question to answer because different, you put 5 smart people in the room, you won't find agreement on what constitutes preparedness spending, right? And what sectors should be included and what sectors should not be included. But rather than kind of saying what's in and what's out, I think what helps is just to say, okay, let's agree on the 5 priority items, interventions that we really need to follow up on. And if these things are in the budget, right, whether they also relate to other spending is kind of irrelevant, right? Or what share of total spending it is irrelevant. What matters to our constituency is whether it happens or not, right? And then you say, this is what it's going to cost. Let's make sure that these items are funded. Let's make sure that we can monitor and track these expenditure items, which then will create an opportunity to have a follow-up conversation the next time around when the next budget is being created. And then you can always say, okay, we'll need to do a little bit better than the year before, but we need to create that baseline first. Thanks. Back over to you.
Thank you very much. That was beautiful. That was, I don't know if anyone wants to add something, but we are
That issue, Faith, around accountability. And during COVID, we saw corruption in almost every part of the world in some shape or form. And, so when we talk about evidence-based decision-making and, clear prioritization, what we value and all of that is very good and very nice. The reality is that it's not happening. And the impact of corruption linked with organized crime is a big threat to a lot of what we're talking about and what we need for preparedness. And this is where a good and strong civil society, certain key freedoms are important in terms of media, in terms of judiciary, in terms of freedom of speech and so on, becomes so important. And those are becoming increasingly rare in many parts of the world, including in Africa. So these are all intertwined issues. And if we really want sustainable futures for generations to come, I think it's incumbent on all of us to start playing a role in terms of being more vocal about where those bottlenecks really are. And I think we're not short on solutions, we're short on implementation of those solutions.
Wow, thank you very much. Thank you so much. I wouldn't know if anyone wants to say something else. However, we if it's out behind our time, and if it's okay to begin to bring the webinar to a close, is that okay by us speakers? All right, thank you very much. A big thank you to our speakers. A big, very big thank you. Please let's show some love to our speakers. Use the reaction button, the thumbs up, the love emojis. Let's just tell them thank you. It's been an awesome time being here. We are not paying them, and definitely we are not paying them for their time or anything. This is just a pro bono for us, and we've learned a lot. So we want to say a big thank you to you. Thank you so much for honoring our invitation, and we hope to still be able to collaborate with you later in the future, probably with one of our conferences. Thank you so much. Right now, we've come to the end of today's webinar, and once again, want to say a big thank you to our speakers for sharing their insights, and to our participants. Thank you very, very much. Like we usually say, without you, there is no Get webinar. Therefore, if we don't have anybody attending, why exactly are we organizing the webinar? But we are here because you are here. So thank you. Today's conversation has really been amazing, and it has shown us that strengthening pandemic preparedness is not just about technical solutions. It also involves sustainable financing, resilient systems, and strong collaborations. So on behalf of the Global Emerging Pathogens Treatment Consortium, we say thank you for being a part of this important dialogue. And we also want to mention that a recording of this session will be available on our YouTube channel at Get Africa. So you can always go back to listen to it again in case you missed anything. Also, certificate of participation will be sent to all registered participants to appreciate you for joining. We would also like to highlight a few opportunities. Get as a journal, that is the Get Journal of Biosecurity and One Health, which is currently open for submission. It's a free publication platform. You can get more information on www.getjournal.org. And also, we are also inviting you to submit for the Get Newsletter Volume 25. And the theme is leveraging public health intelligence for early warning system, early warning preparedness, and health security in Africa. You can submit your articles to omowumi@getafrica.org. The email address will be pasted in the chat, omowumi@getafrica.org. Also, we encourage you to stay connected on all Get social media platforms so you can stay updated with our future events. Thank you so much. Thank you once again. And we look forward to seeing you in our next webinar by May. So thank you so much. And again, thank you to our speakers. Thank you very much to Professor Karim, to Tom, to Maurice, to Mr. Boniface. A big thank you to you. We appreciate your presence. Bye.
Thank
Thank
you.
you very much.
Bye.